And we are absolutely delighted today to present this special research rounds. And this is an opportunity for us to feature one of the winners of the Robert Roberts Research Award as part of our research celebration. And that took place back in December of 2020. That seems like eons ago. But in fact, our research award for the 2020 Robert Roberts Research Award was Dr. Vincent Chan for his publication of the Camera CardioLink 2 study, which was published in Circulation, which is obviously the highest impact journal in cardiovascular sciences. And Dr. Vincent Chan is our talented cardiac surgeon at the Heart Institute and associate professor in the Department of Surgery at the University of Ottawa. And he received his medical degree from Queen's University and subsequently trained in surgery and cardiovascular surgery at the Heart Institute. And in 2012, he undertook a fellowship training at the Mount Sinai Medical Research Center, Medical Center in New York City, focusing on advanced surgical techniques and also research. And Dr. Chan's research interests include the mitral valve repair and replacement, and also minimum invasive surgery, including coronary bypass grafting, and also in terms of heart valve prosthesis properties, as well as mechanical valves. Dr. Chan has received numerous awards, including the Ontario Medical Association Achievement Award, the Detweiler Travel Fellowship from the Royal College of Physicians and Surgeons, and the Wilbert Keon Award from the University of Ottawa Heart Institute Alumni Association. And the Camera Link 2 study is a multi-center randomized control trial showing that the mitral valve repair, either approach of leaf resection or preservation, yield potentially similar outcome. But this is the detail that we would like to learn from Dr. Chan from today's presentation. But the study results will have important impact on patients undergoing mitral valve repair in the future. We truly look forward to Dr. Chan's presentation today, entitled "A Randomized Surgical Trial of Mitral Valve Repair with Leaflet Resection versus Leaflet Preservation on Functional Mitral Stenosis." Dr. Chan, thank you.
Dr. Liu, thank you kindly for the introduction and for the opportunity to speak today. You know, we were chatting a little bit before we logged on about this trial. I mean, the results from this was from our 2015 Heart and Stroke grant, and I'm very thankful to have this published in CIRC last year. But we ran through the lane. You know, this was a grant that I wrote a draft of in collaboration with some colleagues in Toronto that we sent through the internal grant review process. You know, a ton of people reviewed it. I remember Rob Beelan's killing a weekend, basically giving me the most fruitful advice, and for that reason, we're able to kind of get something done. So I'm super thankful for the whole process. I'm going to share my slides now, and let's see. Can you see my slides? I still see my camera on there. Do you see? I can't hear. Can you see my slides?
Yes, we can see your slide, but it's in the kind of the yes, right. Yeah. So perfect. Yeah. So it comes across beautifully. Yeah. Perfect.
Excellent. Beautiful. So thank you again for having me. This is, again, you can see all the authors on this trial, and certainly it's been very much a privilege to have done this trial with so many engaged individuals. So the valve we're talking about is the mitral valve, and I spent a lot of time looking at the left atrium, and this is usually what I see. For those of us who may not be as versed, I mean, the mitral valve is about 4 or 6 square centimeters in area. 2/3 of the coaptation of the mitral valve is from the anterior leaflet. There's also a posterior leaflet as well. These leaflets themselves are supported by chordae tendineae, which are attached to papillary muscles. There are generally two major clusters of papillary muscles, both on the anterolateral side of the heart and the posterior medial side of the heart. Each of these papillary muscles may themselves also have individual heads depending on the anatomy. There are a variety of different ways that we can classify mitral regurgitation. And one commonly used mode is a functional classification described by Alain Carpentier. So we have type 1, type 2, and 3 lesions. Type 1 lesions refer to mitral valve leakage due to annular dilatation. So in type 1 lesions, the leaflets themselves are normal, but due to some dysfunction of the left ventricle where the LV stretches or dilates, or due to tethering due to coronary disease, you can have derangement of the annulus and then associated mitral regurgitation. When we go to the other end of type 3 lesions, this involves mitral regurgitation due to some degree of leaflet tethering or restriction, whether it be through diastole or systole. And what we're talking about today relates to type 2 lesions, where you have a mitral valve regurgitation due to excess movement of one of the mitral valve leaflets, most commonly the posterior leaflet. Within the spectrum of degenerative mitral valve disease, which comprises the type 2 lesions according to the Carpentier classification, there is actually further subcategorization based on what we see echocardiographically and also in surgery. We have all the way from fibroelastic deficiency, what we call FED, where you have not a lot of excess tissue of the leaflets, but you can have an abnormality of a focal area where the chordae tendineae themselves are a bit thin. And if these thin chordae are subjected to stress, which you can have with just opening and closing of the mitral valve over time, then you can have a valve leakage. On the very far end, you can have Barlow valve disease, where you really have a ton of excess tissue in addition to derangements of the annulus and subvalvular apparatus. So this is a very common picture of what we see. So in patients with fibroelastic deficiency, you can see here a 2D echo where you can have some excess movement of the posterior leaflet here as it meets the anterior leaflet. If we were to look at this intraoperatively, what you can see here is you can see, this leaflet, there's not a lot of excess tissue. All the free margin chordae here are very thin. And you can envision that if this mitral valve leaflet has to open and shut 80 times a minute or so every single minute of your life, you can envision that one of these might be able to pop, and then that can be a source of the mitral valve leakage. And then the way that we would repair this is with an annuloplasty, which you can see actually the annuloplasty sutures and then the sides are in place. When we look at FED plus or fibroelastic deficiency plus, this is along the spectrum where you have a lot of excess, a little bit more excess tissue, usually focused to one scallop of the mitral valve. We label the anterior and posterior leaflets 1 to 3 as we move from lateral to medial. And here you can see on this echo view, just a lot of prolapse. You can see that this posterior leaflet comes way above where the anterior leaflet would be. This is a legitimate MR that even I can diagnose on echo. Intraoperatively, we see this. There's a little bit more tissue, as we can see here, compared to the last video. And the excess tissue is really focused to this middle scallop here, what we call P2, and not so much the lateral and medial scallops. And as you could see as well with the last little bit of the image was that as well, the free margin chordae themselves were a bit thinned out. So when we talk about surgical mitral valve repair, there are two main treatment strategies. We can either resect, either we cut out the thing that's leaking or dysfunctional, or we can stabilize the valve scallop that's leaking too much by adding artificial neocords. So these artificial cords are like sutures that you kind of sew on to support the valve. In terms of technique, this is how we generally do it. We can either make a very small midline sternotomy, usually a few inches in length, where we can gain access centrally to the valve, or as well, we can do this through a small anterolateral thoracotomy. This is quite a small incision that we can make under the breast in women, and then around the nipple region in men. You can see these bullet holes here. This is actually how we get them on the heart-lung machine. We put a camera in this port here, and we can also put a cross clamp through another stab wound through the axillary space. In regards to resection, there's two main kinds of resection. We can either cut out a square or we can cut out a triangle. So for a classical quadrangular resection, that middle scallop that is moving too much, we cut out that square wedge. As you can imagine, if you were to sew this edge to that edge, it's a bit far. So whenever you put something under tension, it could tear. So the way that surgeons have come up to try to allow this setup is that you can put annular sutures here to basically placate the annulus more, bring in those two leaflet edges more, so that the leaflet edges are just physically closer, and then you can primarily reapproximate them before doing the annuloplasty to complete your repair. When we cut out a triangle, you cut out the wedge on the free margin, but you don't go as far to the annulus. And what that means is that you don't have to add those extra sutures to placate or plasty the annulus more closely together in that region. And then you reapproximate what you cut out before completing the repair with an annuloplasty. I mentioned very briefly, you can add artificial neocordia, and there are a variety of different ways that people can do this. Either you put one suture here and then up to the leaflet. You can do what Tyrone David does at Toronto General Hospital, where he takes one suture and does multiple passes between the papillary muscle and the leaflet. You can do what they do in Leipzig, Germany, where they sew a slew of cords on a loop that's anchored to the papillary muscle. But all of these permutations involve using an artificial suture to go from the papillary muscle to the free edge of the leaflet that's moving too much. And these artificial cords, or neocordia as we call them, are made out of polytetrafluoroethylene, which is Gore-Tex. So the same type of material that we're all wearing now on a cold autumnal winter day. One thing that you can probably appreciate is that for us to fix a valve leakage, these two techniques, is that when we use these two techniques, we generally have some type of plication of the mitral valve apparatus, whether it be at the leaflet level or even at the annular level. So very intelligent cardiologists over the years have asked questions related to the fact that, well, would we ever get into a scenario where we can make the mitral valve apparatus too small? And in fact, this elegant question was asked by Dr. Quan Chan here at the Heart Institute. And he undertook this study that I was privileged to be a part of. And we basically looked at a selected group of patients that had mitral valve repair surgery. So we targeted consecutive patients that had a certain kind of valve repair where he thought that it was a little bit more extensive, involving annuloplasty with perhaps smaller valve size. And out of the cohort of patients, there was 110 patients that had mitral valve repair involving more than one scallop that had surgery between 2001 and 2010. And these patients had on average an interval about 4.2 years, I should say years, from the time of the study, from the time of their operation to the time of the study. And the plan was to do an echo assessment at rest, at stress, as well a 6-minute walk test, and do other markers to determine if there was evidence of functional limitation and or congestive failure, even in the absence of recurrent valve regurgitation. And from this 110 cohort, a cohort of 110 patients, Dr. Quan Chan basically parsed them into two groups. One group involved patients that had a mean resting mitral valve gradient that was less than or equal to 3, with those in another group that had a resting mean gradient that was greater than 3. These were young patients, 60 years of age on average, predominantly male, low comorbidities, generally posterior leaflet pathology. And what we found was that patients that had a higher mean gradient, which is not very high, included 4 or 5 millimeters of mercury at rest, were found to have a higher heart rate at rest. There was also associated a higher peak mitral valve gradient at rest. And at peak exercise, through bicycle ergonometry, Patients with a higher mean gradient at rest had a higher peak and mean gradient at exercise compared to those that had a lower transvalvular mitral valve gradient at rest. And if you look at these numbers, the numbers were quite high. Like if you look at, you can envision a patient with a mean mitral valve repair gradient of 4 millimeters of mercury, and then at stress, they would have a mean gradient that went up to 14 and a peak gradient that went up to 25 with associated elevation of pulmonary pressures. So we have this bias in mind in Ottawa specifically, where when we're trying to reconstruct a mitral valve, for sure we're worried about valve leakage, but we also want to make sure that we don't make the valve opening smaller, and we worry about late mitral stenosis, largely because you don't want to have a patient that's young, still having some residual symptoms, even in the absence of valve leakage. So is there a role to assess this in mitral valve repair? So years ago, when the group in Toronto really wanted to do a study together, although they did not know really what and how, we came back and proposed this trial where we would do this multi-center trial. And the objective of this was that we would compare mitral valve repair patients treated surgically with either a resection or a non-resection technique, which hadn't been done formally in a prospective fashion at all, but then to also assess specifically whether or not there might be some functional mitral stenosis in these patients. So our objective was to compare surgical mitral valve repair prolapse using either of these two techniques for functional MS, and our primary endpoint was mean transmitral repair gradient at peak exercise a year after surgical repair. This was a multi-center trial. We started this off with Toronto and ultimately included 5 other Canadian centers. We wanted to eliminate the learner aspect of mitral valve surgery so that all surgeons enrolling patients into this trial would have done at least 15 degenerative repairs annually and had a very high mitral valve repair rate. 15 repairs a year may not seem like a lot, but when you look at the STS registry, in fact, the median number of mitral valve operations performed by a North American surgeon per year is 5. We wanted to keep the cohort to be specifically patients that had posterior leaflet prolapse. So we wanted to avoid having patients with anterior leaflet or commissural pathology. We wanted to make sure that other etiologies of valve regurgitation, such as endocarditis or rheumatic valve disease, were off the table. Other things such as mitral angular calcification or ventricular dysfunction that could cloud the results of our study, we also wanted to make sure we took off the table. And based on these previous data, we calculated that we would have had enough power with a sample size of about 88 patients with our continuous outcome of the mean mitral valve gradient at stress. So we consented ultimately 104 patients, and we randomized all of them to our trial. In terms of allocation, in the end, 54 patients were allocated to the leaflet resection arm, and 50 were allocated to the leaflet preservation arm. So the way that we conducted this trial was that we would have the patient consented, and then in the OR, we verified the echo findings on transesophageal echo before the surgery. And what we did was that we made the randomization commensurate on the surgeon being able to say that they can do either one of these two techniques. So in fact, we only randomized intraoperatively once the cross clamp was on the heart, cross clamp was on the aorta, the heart was stopped, and the surgeon had actually done their preliminary in situ assessment of the mitral valve and determined that he or she would be able to use any one of these techniques. So in spite of that initial assessment, we had 54 allocated leaflet resection. 3 did not receive the allocated intervention, 2 due to investigator-initiated discontinuation, then 1 due to crossover. 5 in the leaflet preservation arm did not receive the allocated intervention, and 2 due to the investigator and 3 due to crossover. Our primary endpoint was a 1-year stress echo endpoint. 6 in each group ultimately did not come back to have that test, which meant that we had 46 in the resection arm and 42 in the preservation arm available for analysis. And as I showed in the last slide, that we had, based on our power calculation, that we would have had sufficient power to be able to determine difference. Patients in this study were young, with an average age of around 65 years in the overall cohort. This cohort predominantly involved male patients with a low surgical risk and a low STS perioperative calculated risk score, and they had few comorbidities with normal end organ function and normal associated renal function. These patients had severe mitral valve regurgitation and without evidence of MS and generally preserved left ventricular function. At surgery, patients had mitral valve repair with annuloplasty. The mean annuloplasty size was 33. For those patients that underwent resection, the resection strategy was triangular in the vast majority. Chordal transfer, which involves moving a native in situ cord, was part of a protocol, and that occurred in some patients. And about a fifth of patients had some type of concomitant surgery, whether it be bypass grafting, closure of PFO, or associated Mays procedure. This slide essentially summarizes our findings from the study. So at 1 year, our primary endpoint of mean mitral valve gradient at peak exercise was not different between groups, 9.3 following resection versus 8.1 versus leaflet preservation, which now gives credence for either leaflet strategy in general, and then also for the primary endpoint that we highlighted. We also had a variety of secondary endpoints as well, where we assessed the resting peak gradient and the resting mean gradient as well. There was also no difference in the 6-minute walk test at a year. So in summary, we report the first prospective surgical randomized trial to evaluate these two commonly used mitral valve repair strategies to address posterior leaflet prolapse, leaflet resection, as well as leaflet preservation. Both yield acceptable results with no difference in postoperative valve gradient and functional status 12 months after surgical mitral valve repair. In fact, this is the hardest slide, I think, to put at the end of any talk of this nature, just because there are so many people involved at every level, from the design, grant application, execution, and ultimately analysis. So for all the people that have been involved that helped push this cart up the mountain, I'm eternally grateful. And thank you very much, Dr. Liu and Research Services, for the opportunity to present these data today.
Great. Oh, thank you so much, Vince. So I know doing surgical randomized trials, is like almost next to impossible task. It's like climbing the Himalayas. And but it's really a tribute to the fact that you can actually get so many of the expert centers linked together, to answer this common question. This is, I think, sort of one of the key paradigms, in terms of really answering top of mind questions, for folks who may not be able to obviously address these on their own centers. Yeah. So we have a number of comments and questions coming in. One from Dr. Mark Ruel, and he said that this is a presentation from the young Jedi in our team. And Robin Lenz also congratulates you on the randomized trial. And the question is, do you think there are subsets of patients who would benefit from one versus the other? That is that not necessarily totally equipoise, and particularly, after the results of the trial now available, when you actually, sort of take a deeper dive and things like that, are there kind of a nuanced considerations for the approach? Yeah.
No, that's an excellent question. The privilege of having such a strong team to go with is that even in Toronto, Kim Connolly now is delving into the echo data to try to maybe provide some insights into that. It's a tricky one. I think that at the end of the day, the problem with surgery is that it is a little heterogeneous, where what you get with one provider may not be the same as what you get with another provider. Here we try to have a discrete phenotype with a outline direct strategy to fix the valve. But even then, it's tricky. You're there, the cross counts on the aorta, you're looking at this thing, and we did find that a lot of surgeons did not really want to get into it, where they maybe wanted to go one direction with one strategy and not the other. And I completely get that piece. I think that in this trial, most of these patients are actually Dr. Misanda's in mind, just because you're going to enroll patients in your own trial. But for sure, that's the case. I think that as we move towards less invasive strategies, I think that a neocord approach is a little bit quicker. It's a little bit easier. It's a little bit more reproducible. I think that our culture in mitral valve repair is moving that direction, because when you start cutting stuff out, you can't really erase the mistakes, right? You can't really go back. But if you're only adding cords, you can always cut those out and then start again. I do like resection. I mean, a lot of this is my bias based on the mentors that treated me, namely Dr. Misanda and Dr. David Adams in New York, where I still like the fact that if the in situ native chordae are good and you can bring that together with resection, I still have the bias that that's a more durable repair. Neocords are great, but it's still a suture. You have to bet on them holding. So for me, I still kind of have a bias towards resection. But if I were to answer your question, I would say that I would look at the discrete subset where the chordae that I have remaining are strong. And if that's the case, I probably would go resection more than leaflet preservation.
Right. Yeah. So that's a very good point. So certainly your assessment, of the patient's various features all contribute. Also comments from Jim Robley, who's really appreciate your excellent presentation. And so his question is kind of similar in that, do the results influence your current approach, towards repair for a given patient, so a little bit similar to what you mentioned already. Yeah.
But very good. I think that, for me, my bias initially was more towards resection. I think looking at these data and just tracking those patients, which we were already doing, but then now you have a core lab that really tests your echo, that the ones where you put neocordia on, they weren't, those valves weren't necessarily flying off, post-operatively. And for sure, I would say that it's giving me a little bit of confidence. But listen, I mean, Quan Chan was on us since 2010 about small valve repairs, and to have him down the hall, I mean, I think that's been the biggest influence, really, to keep me honest for valve reconstruction.
Right. Speaking of Quan Chan, in fact, Quan does have a question, and so the question actually is whether the lack of difference between the two approaches may be due to the fewer cases who actually needed a complete ring. Is that a contributing factor for the the result you found?
Yeah. That's a fantastic question. We published a variety of papers actually from that rich cohort of data that Quan had amassed. We compared complete rings, partial bands. It was interesting because we tended to use a partial band in Ottawa, largely due to Dr. Misanda's influence, which actually still persists today, because I generally believe that's a better angioplasty system. But the market share in the world, everyone uses a complete ring. They use the Edwards Physio 2 now. So for us in the trial, to get people to want to get buy-in, and for us to even get patients, with more external validity in this, we used the Physio 2. We used a complete ring for all patients in this trial. So here we use a complete ring. We didn't really want to get in the weeds of having different angioplasty systems. We've had a paper that suggested a complete ring might be deleterious for a variety of reasons. But here the average size was about 30. The mean size is 33. So we put a lot of 32s and a lot of 34s in. It'd be difficult to really worry about mitral stenosis, I would think, just because I think everyone was a bit sensitized to not using, something smaller than a 30, which we have shown actually with Quan's data that it's not as optimal.
Right. Okay, so that's actually very insightful. A related question from Karen: Hey, are you routinely using annular rings versus flexible bands? Are there any, preferences or of different approaches to this? Yeah.
Yep. Our major play is Medtronic Future Band. That's a semi-rigid annuloplasty. Not, so not because of any other reason than the fact that I think it's a pretty solid band. It maintains the shape. It's partial, so it goes just to the trigones. And in practicality, you leave 3 stitches between the two trigones on the anterior leaflet, and then you don't limit anterior leaflet excursion. But again, those are the biases that I probably, inhaled from Dr. Masana, over the years. But I sincerely believe that bit of counsel.
Right. Rob Abinlands has also another question, and that whether you think the surgical experience, had any effect on, sort of the findings versus, sort of the approaches also to mitral valve surgery these days.
That's a good question. We went at the outset of trying to have a bar where we had some minimums in regards to mitral valve surgery. Now, on a data level, my understanding was that there was no real difference in terms of valve leakage, in terms of even center, which makes me think that probably the expertise was there. Every center had there 1 or 2 main players involved in the case. I think it's moving in that direction. The outcomes are expected by patients. I mean, cardiologists are smart, right? I mean, if your patients aren't good, like they'll know. Echocardiographers are good, like they're going to find your problem. They're going to show you what it looks like. So I think it's getting more difficult to try to sell average surgery. And what we've seen across the country is physician surgeons just more interested in a certain area, and it's gone that direction.
And a follow-up question from Rob: what about experience with one techniques versus the other? Do the surgeons have equal, sort of comfort, in terms of the approaches? Yeah.
Yeah, we didn't really get all that granular data. When we had our design meetings, everyone kind of just said, yeah, we can do it. And we didn't really ask for any specific data. If you really want to look at it, I mean, very few surgeons have their earlier long-term results published. I think that's one piece that is interesting. Again, the system here with Dr. Masana, he set up a database, he follows patients. And that kind of continued on like this. And I think that, for sure cardiologists will know what's happening with the patients, but, there's also a bias towards some of the adverse outcomes. Like you'll remember the bad stuff as well. So I think that you really need to have clear data to assess. We never really had that for the surgeons. I suspect that just the number of patients that were enrolled, the fact that some centers and some providers were less willing to enroll, I subjectively thought it might have been related to that, because you have to say at randomization that you're good with going one way or another. And for sure you can see that some surgeons enrolled more than others, which you don't know, but you can imply as them not wanting to go, one direction versus the other.
Yeah, no, given now a number of the mitral procedures are, kind of can be done, percutaneously, there are a number of these questions also arise. And, so do you think this is a potential opportunity for one to begin to actually look at a larger picture of, sort of addressing the mitral set of diseases?
Yeah, absolutely. Like we plan on flooding Oracle Innovations Hub applications next month with some ideas. I'm privileged to be in this space. I'm privileged to work with, Donna Nicholson, Adam Dryden, Mark Hines, David Masika, Ben Hibbert, Maria Labanaz. I mean, it's a really fun environment to be in where you can have these kinds of conversations. I agree with you. I mean, surgery, us cutting you open, doing this kind of valve repair. Right now, this is still the gold standard. 10, 20 years down the line, I don't know, right? I think that for sure, and I've had this conversation with many in the building, that as we're moving towards a percutaneous repair, there may be anatomic subsets that would be very amenable to percutaneous repair. Now, the interesting thing with this data, and hopefully it'll come out more apparently in our sub-analyses, which in fact is actually a trial that we retrospective, sorry, the idea of this trial is one that we've actually written a paper on years ago, looking at posterior prolapse. But you'll find that even when you talk about P2 prolapse, which is the most common type of prolapse, it's very heterogeneous. You can have a big P2, you can have a small P1, small P3. The width of the flail can vary depending on the number of cores that go to this. So I would say that all P2 prolapse is not created equal. Dr. Msani used to always say this. We had some data from the database and we proved that sentiment. And I suspect as we get more nuance with structural valve therapies, we are going to see this, right? So the things that as surgeons that we were always lamenting, where we looked at the size of the annulus, we looked at the size of the scallops and neighboring chordae, which we still can always see well with echo. We're going to see this piece play out in the structural space. So it's exciting. I think that it's super cool. I think to be in this space and to kind of work out these problems over the next 5 to 10 years.
I guess maybe last question from Jim is that are there any specific next trials? I guess this is similar to what we discussed earlier, but are there next trials that you are planning in terms of the mitral repair, domain?
Yeah, I mean, 100%. I mean, there's it all comes down to will. I think to execute. I mean, ideas can come quite easily. It comes down to will and who's willing to work together. I think that the one thing is just having gone through the trial and having some friends at other centers, it makes it a little bit easier to run the next. I would say, and I would say this even if my colleagues from Toronto were logged into this call, one thing that I would like to do more next time than this time, and it would help, especially now that David Masika is with us, is I'd like for us to kind of run the core lab, and to try to have more of a stream to kind of run that trial. But listen, I'm super thankful to Subodh Verma, super thankful to David Mazer. These are high quality researchers, physicians, and people that really made this trial with their expertise. So, certainly to go in with them, it would be a privilege as well.
Yeah, so this is great, because now you have a proven track record and you have a network which now you can actually grow, with the need of, for example, of additional members and also at the granting agency, right? You have also a proven track record as well. And so this is a great foundation for you to really build something that's enduring over time. And so I think, and that, you have a set of great friends and colleagues, to work together to solve problems. Yeah. So this is really exciting. Yeah.
So we'll continue to push. It's not enough to just kind of sneak one through, right? So it's nice.
Right. Yeah. So on behalf of the whole community, congratulate you again for the award, and certainly is through a tremendous amount of determination and effort to make this trial possible to start with, but at the same time, being able to complete it and to have the scientific advance, for the entire community, but also for the patient population as well. So this is really a tribute for great work and contribution. And so on this note, we thank Dr. Chan again for the excellent presentation, and also the folks who contributed questions. And so we will have another round next session, which is on January the 18th. And the special speaker is invited by our trainee committee. That's Dr. Ulrich Wisloff, who's a professor and head of Jacob Center for Exercise in Medicine in the Norwegian University of Science and Technology from Norway. So it should be something quite interesting to look forward to as well. So I'd like to Thank everybody who joined us for this session. Thank Dr. Chan again for the wonderful work and the great presentation. And hope everyone have a great day and take care, everyone.
All right. Thank you, Dr.
Yeah,
Liu.
thanks again.